I think we're ready to get started. Okay. And I know we have dual interpretation in Spanish and in English. And I want to welcome everyone to our Child Symposium. And this is a work that represents, well, at least for the work that INL has been doing, represents about 14 years of work. I know for SPYM it might represent many more years, and so it is such a joy to be able to work with two fantastic partners, colleagues, and friends that I have with me on the stage today. So my name is Dr. Hendrée Jones. I'm a psychologist that works in the School of Medicine in the Obstetrics and Gynecology Department at the University of North Carolina in Chapel Hill. And for 10 years, I had the honor and the privilege of leading a treatment center for women and for children that have drug problems. And I'll talk a little bit more about that journey, but I really want to introduce my colleagues. And so their bios are a bit long, so forgive me, I'm going to read them. So the first one is Dr. Maria Carmen Sanchez Molinas, and she is going to be talking about the implementation to complete the course of the child curriculum in Spanish. Dr. Sanchez is a pediatrician from the National University of Ascension. She's a specialist in the treatment of addictions and teaching in higher education. Among her many accomplishments are that she obtained the certificate of completion in courses 1 and 2 of the child curriculum in Campinas, which was the first time that we ever trained the child curriculum in South America. She has also completed the certificates for courses 3 and 4, and she did that in Buenos Aires. And then the final one, she completed her courses of 5 and 6 in Sri Lanka. She has also achieved the Universal Treatment Curriculum's accreditation certificate and obtained the trainer's certificate in SOGI in Chile, which is our unique treatment or intervention for people that are LGBTQIA+. She obtained her training of trainers in South America for the child intervention. She has collaborated with the work in Washington, D.C. in 2015, was the coordinator of the Child and Youth Program Detoxification Unit until 2022, and that's really how I got to know Dr. Carmen, because she was the only pediatrician taking care of children under the age of 12, and teenagers too, but under the age of 12 in Paraguay. So she is a pioneer in what she does. She's a board member of the Paraguayan Society of Psychiatry and is the ISA Paraguay Chapter Board Director. So let's welcome Maria Carmen Sanchez. All right, our next pioneer is Manish Kumar, who I have to say is one of the hardest working, most influential, delicate, and diplomatic people I've ever had the chance to work with. And he gets everything done with exquisite attention to detail. So Manish is a management graduate, maybe that's why you're so attentive to detail, with over 15 years of experience in the health sector, and is currently serving as the team leader at SPYM, a national not-for-profit organization. Now, anybody might be impressed by that, but having worked with SPYM for the last, 8 years, they have just hundreds of programs. And every time I think I know all the programs that SPYM is doing, they surprise me with something new. So I can't imagine how busy the team lead is at SPYM. Let's see. He has provided vital program training, implementation, and management to support the Department of Health and Drug and HIV prevention and treatment. His key contributions include expanding the targeted intervention program for high-risk populations and initiating medication to treat opioid use disorder treatment across various settings. And anybody that has ever tried to do that knows the vast stigma and discrimination that the workers working there face in addition to the patients. So what you're doing is life-changing and life-saving. Let's see, he's conducted community-based research among marginalized groups. He's assessed drug dependence programs, identified gaps in service delivery, and in collaboration with the All India Medical Institute and other government bodies, he's coordinated research projects, including ours, right? And to estimate substance-using populations and improve programmatic outcomes. His work demonstrates heart and dear and deep, strong commitment to improving public health services and addressing the needs of those who are most vulnerable. So please put your hands together and let's recognize Manish Kumar. All right, so what we're going to do today is I'm going to let these two amazing people talk for as long as they would like to talk, because they are trying to put thousands and thousands of hours into a 20-minute presentation, and they deserve more time than that. So I'm going to keep my presentation to that, but I want to make sure that we get to hear from the two stars of the show while I just kind of set up the background, okay? All right, and then what I'd like to do is have everybody present, and then we can have a conversation. Does that sound okay with the audience? Okay, cool. I have a video in my presentation, so I'm going to have to toggle back and forth. And so just know it's from SBYM and some of the media coverage, because I wanted to bring a face and voice to children. One of the things that I think is really important whenever we do work with patients that have substance use disorders or substance use problems is that we have their faces and their voices and their living experience to guide us, to learn from them. And so, and sometimes it's only images. If you were in the women's work, you know, I only showed images today. Today we will, if the video works, let's cross our fingers, we'll get to actually hear the children from their point of view. Oh, let's see, okay. So here we go. I am going to take you on a 12 to 14-year journey, depending on how you want to define it, to walk you through what we have been doing to identify, assess, and treat children for substance use disorders. And we're going to hear from experiences across the globe. There are a whole lot of people and different international bodies that help support this work, and you can see them listed on the slide. I have to thank the International Narcotics Law Enforcement of the United States State Department for their continued financial support of this work of child and related projects. We need to thank the Colombo Plan for coordinating so many of the pieces of the work that I will share with you today. The UNODC has also been a partner and a recipient of funding to implement this work. And the governments. We have been in partnership with Argentina, Brazil, India, the Islamic Republic of Afghanistan, that have helped us learn how to treat and prevent drug use in children. The National Institute on Drug Abuse, which funded the randomized clinical trial with the preliminary data that I will share with you today. And also, there are a series of webinars that have been put on by Ms. Aditi, Dr. Rahana, Dr. Beatrice, and Mr. Franklin, as well as Natalie. And so for them, I'm incredibly indebted for them sharing their data and leading that work so that more people can have access to this treatment. And here comes Rahana herself. Hello, Rahana. You just got mentioned as one of the wonderful trainers and leading the webinars. All right. So the work I'm going to share with you today is a little project history, the randomized clinical trial data, and our future plans. And I'd also like to recognize Ann Chick from INL, as I just thanked INL for their support, so let's give her a round of applause. Thank you, Ann. You are in very good company, because the three of us met each other in the middle of the street and we're like, where are we going? But we found it, and that's what we do. We persevere in this field to be able to find things. Okay, so this work really started in Afghanistan, and that's just a picture, actually, of a reporter who is in one of the child treatment centers. I'm not going to show you that video for sake of time, but this is just some examples of their faces where you can see and get a little bit of sense of what they look like and how young they are. So when INL first identified the problem of what we called at that time child addiction, they were doing a national drug survey. And they started recognizing that a large proportion of the people in Afghanistan were consuming different types of substances. And so they did a large household survey, doing a more deeper dive, and not only assessed the adults, they also assessed the children. And what they found was that in children, that's what the data are showing you here in this slide, and this is in 2012, that there were different types of opiates showing up in the bodies of children. And this could be from a hair sample, a urine sample, as examples. And so what you see is that the types of opioids that the children living in the homes were testing positive for was 48% opium, 20% codeine, and then 32% mixed heroin and opium. When they looked at where were these children getting the sources of their opioids from, they found that almost half, that 48%, were given to the children by the adults. And for example, there were children that when they were born, they would make little X's on their back and put a little opium paste. And what they found is because many of them had been prenatally exposed to opiates, putting this opiate paste on their back would soothe the withdrawal, that those negative effects that you get when you no longer have opiates. Another example of how the children had been given opiates by the adult was that the child would be like 3 or 4, for example, and hungry, and the parents would blow the opium smoke into their faces because it decreased hunger. It also was a behavioral control mechanism. For our women who are spending 18 hours a day weaving carpets, that this was a way to babysit their children and decrease hunger. Other examples were environmental exposure, and with environmental exposure, that meant that the opium smoke would be in the bedclothes, would be on the walls, would be on their toys, would be on things that they would touch. And so there was that secondhand and tertiary exposure to opioids. And so when this was identified in very young children, it became increasingly apparent that there needed to be an action and a response. And the other question was, does this only happen in Afghanistan, or is it happening in other places too? And so the more that INL looked into this, they found that there were examples from many places around the world where children were victims of the drug trade. Example, in Brazil, the children of 5 or 6 years old would be given a crack cocaine rock to put into their pocket, and then they take it across the street and they give it to the drug dealer. They get paid and they bring the money back to the person that gave them that rock of cocaine. And then they would start paying the children in drugs. So we started observing more and more examples in children between the ages of 5 to 12. And so we looked in the literature, and actually sort of the way I got involved with this, because that work had been done before I became involved with the INL and the Colombo Plan and the UNODC. They called me, NIDA, the National Institute on Drug Abuse, called me, and they were like, "We've heard about your work with prenatal opioid exposure. You must know something about children and drugs." And what I knew about children and drugs was really just from the prenatal standpoint and what could happen in subsequent long-term outcomes. But they asked if I would be willing to go to Afghanistan with a group of people, and I said yes. And it was one of the best decisions I ever made in my life, because I have met more wonderful people, including the two of you on this stage, because of that work. So we know, and we kind of had to start from nothing, because what was out there when I did a search of the literature, there just really wasn't much published about children under the age of 12. There were certainly adolescent studies, but there weren't children's studies. And so the whole child intervention was to respond to this growing threat that was happening around the world. It represented innovation and pioneering work on the part of INL to be able to expand this international demand reduction work. And so, but nobody was a child expert at all. And so we needed to gather all of the experiences that we could, all of the experts that we could that were working in different ways with children, and we really started from ground zero. So the work that we did in Afghanistan was very much based on sitting and having multiple cups of tea to understand what was happening in the circumstance. We then needed to layer science and evidence. What do we know about the developmental aspects of children? What are the educational aspects of children that we needed to understand? And we knew we couldn't do this in isolation, right? That we had to have much of a spectrum of services. And we couldn't treat the child absolutely alone. We needed family involvement. So what were the family threads that we could do? We also wanted to be able to provide treatment and prevent future recurrence of drug use. And Afghanistan is one country, right? What we learned in Afghanistan can't really be necessarily applied exactly in any other country. So there needed to be a flexibility in the protocols to tailor it for each country. Each country needed to be able to see themselves in the protocols for them to work. So what did we do? In the last 12 years, we first identified measures. So we developed a screening battery, and we needed to screen children for psychological issues, for physical health issues, for other types of behavioral issues, for trauma. And then we realized once we got this great screening battery, we didn't have an assessment measure. So we could screen, we could tell you what was wrong, but we couldn't tell you how bad it was. How bad was that substance use disorder? How severe was it? And so we got with our Argentinian colleagues and the United States, and we developed a validated child care assessment. So now we've got screening, we've got assessment. We needed to have that comprehensive response. And so we developed all sorts of different ways of healing trauma and being able to do it in a child-friendly way to help heal the family in pieces, to help heal the trauma that children are facing, and to give them a safe place to be a child. So we needed to also determine the feasibility, the efficacy, the acceptance of this. We had pre-post data from Afghanistan, which if you've ever worked in a conflicted country, it is no easy task getting pre and post data. And then we needed to test the ability to disseminate what we had done. And so as these protocols were building and more people were being trained on them, we needed to know, is the training working, what we're doing? So we did pre and post test of the training. We showed we have an effective training. We can increase knowledge that people have of how to do this. So what does it look like? So we've got 6 courses with the 7th course in development now. The first one is just an introduction. The next one is, what are those special, unique counseling considerations? We can't talk to children like we talk to adults. So how do you understand developmentally, be on the child's level? We trained in motivational interviewing, which is that empathy, that's seeing the world from the child's perspective and being able to guide. We have a whole course on trauma, that attachment theory, how the children and parent bond is working, what we need to do to heal it. And then we have a course on pharmacology, because the idea was, what do you do when you have a child in front of you? What are the first and subsequent steps you need to do? And sometimes you need medication to be able to withdraw the child. And then finally, the suitcase for life, which is the intervention tool that has 8 different modules and all sorts of things like art, motivational interviewing techniques, mindfulness techniques, breathing techniques, basic dialectical behavioral therapy techniques. And we do it in a child-friendly way. We play games. We tell stories, and they get to finish them. So we're teaching communication skills, we're teaching self-advocacy skills. So these are some of the examples of our wonderful training teams that we've had from 2010 to 2018. You can see how the suitcase for life used to look like a doctor bag, a big black doctor bag, and now it is a light, fancy suitcase, or a backpack. Where Child has been disseminated, we've had 16 trainers from South America, 30 from Asia, Africa, Australia, Europe, and North America. We've had webinars monthly thanks to Rahana and her team since October of 2023. They've had over 221 participants from 26 countries and 16 different disciplines. So it takes a village, if not a city, to be able to wrap your arms around children. And they average about 50 to 80 participants. And then we've had echo training. Oh my goodness, this is amazing. Like, whole countries are beginning to pick up, and you're going to hear a wonderful experience from Maria Carmen. So we have a toolbox, we have a comprehensive intervention protocol, and we have a model of action that is rolling out around the world. What we didn't have was randomized clinical trial data to support or refute its relative safety and efficacy. So, India was selected, given the numbers of children that are there, and we know that many children are living in street circumstances. And so I want to share with you the video, and let me see if I can do it, so you can hear the voice of the child. And I'm not going to play the whole video.
And substances. The number would go up if school-going children are included. Experts say the age of initiation into drugs is getting younger. For example, 6-year-old Firoz, not his real were abusing drugs and substances. The number would go up if school-going children are included. Experts say the age of initiation into drugs is getting younger. For example, 6-year-old Firoz, not his real name, who has not yet lost his baby lisp.
मेरा भाई तो चिका था और मैंने भाई को देखते मैं ही चीख गया था.
अच्छा लगता था करना? नहीं अच्छा लगा. फिर करते क्यों थे?
अच्छा.
His brother is 8. The family is poor. While the father is disabled and unable to earn, their mother has a small tea stall.
नशा करने लग गए. इसमें हमारे दोस्त का पैसा सब लोग आधे आधे मिलाते. 25 रुपये मम्मी से लेता, 25 रुपये चोरी करता. बीड़ी, फिर रुमाल वाला, फिर उसके बाद गांजा.
It's a shame for us as a society, as a civil society. It's a shame because if we cannot protect a child of 5 or 6 years, then what we are going to protect?
Right? If you can't protect a child, then what are we doing? So thank you, Dr. Kumar, for allowing the videos to come in. Yeah.
Because they are the future. And
So just a little more of the background for our randomized clinical trial. So we did a couple of initial studies with SPYM, trying to get a sense of what types of substances the children were using that were coming into the centers. So we found mostly tobacco. About half were using alcohol, half were using solvents, there's inhalants, 25% cannabis and 3% opioids. And then the children that were in treatment, their primary substance use coming in was solvents, and then opioids, and then cannabis. So our aims were really informed by that preliminary data, and we wanted to see if taking the beautiful work of SPYM, we could also layer onto that child, and if that would do any good. And so our outcomes were longer duration of treatment and then greater reductions in psychoactive substances up to 12 months follow-up. We also have 2 additional aims, but I won't focus on those for sake of time. So this is just the consort diagram of our randomized clinical trial. The children came in, they got consent, they determined eligibility, we randomized them to usual care or usual care plus child, and everybody filled out the forms at the same rate. So as we can see here, most of the children were male, and we had 11% female. And then most of the children came from Delhi, with a couple of outlying areas. These are the data to populate. So this study was also done under COVID, which was amazing with the work that they did, that we had 344 children. We focused on the ages of 7 to 12. All of the children were able to be eligible because we made very broad criteria. And what ended up, we had mostly solvents, a little bit of over a third cannabis, and 11% opioids. And what we found with the opioid children was that most of them were a little older than the other children. You can see the randomization and that we had very good rates of follow-up up to 12 months. When we look at retention and stay, that first primary outcome measure, there was no differences. They did a fantastic job retaining them in treatment. When we looked at 12 months, it's almost like a sleeper effect. We did have a significant difference in 12 months. What this means is that we have outcomes that are really the first safety and efficacy for SPYM in addition to child. There are a couple of quotes from the children that we have, and I love these quotes, and thank you, Manish, and the people below and our team for being able to pull these quotes. And they said things like, the best part about the day is that I like the art and the music we get to do. I like myself, and I learned that I'm a good person. And some quotes from parents when they asked about what their experience was like being at SPYM. As parents, we need to be calm and not get carried away by small mistakes and naughty behavior of children. We have a tendency to have expectations from children about how their behavior is. However, we should be equally careful about our own behavior with the children. And so I share this because addiction is really a child illness. If you look at children, if you ask adults coming in to treatment when they started using substances, the vast majority say their early teenage years, right? And some as young as 3 or 4 or 5. And so if we can address them at the time they start initiating, if we can't prevent it, if we can start addressing it as soon as they begin using, I think we'll have a healthier population and much better outcomes in the future. And so with that, I'm going to stop and turn it over to Maria Carmen to be able to share her presentation. Thank you. It's in Greek. Do we have some help? Okay.
Bueno, buenas tardes a todos, a todas. Es un honor estar acá con todos ustedes y un agradecimiento especial a la organización por permitirme estar acá compartiendo con todos ustedes el proyecto de capacitación Child, intervención en niños para una vida libre de drogas. Esta capacitación lo realizamos en mi país, que les quiero presentar, es Paraguay, un pequeño país situado en el centro de América del Sur, de ahí que se lo conoce como el corazón de América del Sur. Es muy pequeño, pero un corazón muy grande, ricos en historia, ricos en naturaleza, rico en cultura, y tiene una población de 7.454.000, somos poquitos, de los cuales 2.495.000 y un poquito más son del grupo etario de 0 a 17 años. Sería más o menos un 33.4% de la población total. Un estudio reciente realizado por el Ministerio de la Niñez y la Adolescencia han informado que tenemos 22.000 niños y un poquito más en situación de calle, de los cuales el 90% están en consumo de sustancias psicoactivas. También un estudio del Observatorio Paraguayo de Drogas que se realizó con 3.000 niños escolarizados y han informado o ha concluido que el 10,3% de niños han consumido sustancias psicoactivas alguna vez en su vida. Estos datos, estos números son alarmantes y a esto tenemos que agregarle que cada vez estamos teniendo niños con patologías duales, niños que están con que están mal tanto física como psíquicamente. La mayoría de nuestros niños son policonsumidores, consumen varias sustancias, pero la que mayor utilidad, el que mayor usan es la cocaína fumable, que es el crack, una de las sustancias más adictivas y más destructivas, tanto física como psíquicamente. Todo esto se suma a los pocos centros de tratamiento que poseemos en el país. Son contados los centros de tratamiento, con lo que contamos un centro de desintoxicación que es el Centro Nacional de Prevención y Tratamiento de las Adicciones, dependiente del Ministerio de Salud Pública y Bienestar Social. Tiene capacidad para 15 niños para todo el país y hace un tratamiento de internación de corta estancia para desintoxicación de estos niños. Tenemos una comunidad terapéutica en Encarnación, que es una ciudad bastante distante de la capital, a 370 kilómetros, y es un tratamiento de internación de larga estancia que tratan el proceso de rehabilitación, hacen el proceso de rehabilitación. Y tiene capacidad nada más que para 10 niños. El tratamiento ambulatorio sí lo tenemos en el hospital de clínica, tenemos también en el neuropsiquiátrico, que son dependientes del Ministerio de Salud. Viendo todos estos déficits que tenemos y el gran número de niños que están consumiendo sustancias y el mal estado general en que se encuentra, las autoridades promulgaron una ley, la ley 6800/21, que hace que se formen secretarías y consejos municipales. Tenemos en todo el país 260 municipios distribuidos en todos los departamentos del país, que es para prevención y tratamiento de las adicciones. Está la ley, pero no tenemos recursos humanos capacitados para poder hacer estas intervenciones con los niños. Entonces ahí empieza el proyecto Child. Empezamos a pensar qué podemos hacer por nuestros niños. El tratamiento que en mi vida profesional hay un antes y un después de Child. Cuando yo entro a trabajar en el 2018, el tratamiento y las intervenciones que se hacían con niños eran terribles. Eran golpeados, eran encerrados. Entonces, en el 2013 le conozco a la doctora Jones y empecé a implementar el currículum en este dispositivo de tratamiento. Por supuesto que fue bastante positivo. La ISO capítulo Paraguay es la que organizó y implementó este proyecto Child a través de su organismo anfitrión, que es la Escuela de Gobierno y Políticas Públicas Norberto Bobbio. Por supuesto, con el apoyo de la CICAT-OEA, de la ISO regional y también del Colombo Plan, a quien le estoy muy agradecida, el Colombo Plan, tanto Chile como el Colombo Plan de Sri Lanka, nos facilitaron todos los materiales, desde los manuales del capacitador, los manuales del participante, los slides, los pre-test y post-test. Los objetivos, ¿cuáles fueron los objetivos de este proyecto? Primero y fundamental es desarrollar habilidades y conocimientos basados en la evidencia para que se pueda realizar una intervención eficaz en niños con trastornos por uso de sustancias. También actualizar y ampliar los conocimientos que son requeridos por áreas especializadas. También hablamos de apoyar la continuidad y el desarrollo institucional, y lo fundamental para nosotros también es descentralizar los dispositivos de tratamientos existentes, porque son tan pocos los dispositivos de tratamiento que tenemos que se ven rebasados, y hay chicos que tienen que volver a la casa sin recibir esa atención que requieren. Bueno, la metodología que utilizamos, la modalidad híbrida, pensando en capacitar a personas que estén distantes de la capital, porque nosotros, nuestro proyecto es diseminar Child por todo el país. Entonces lo hicimos en forma híbrida, con sesiones sincrónicas, virtuales y también asincrónicas, y las sesiones presenciales. Las sesiones virtuales sincrónicas lo hacíamos 2 horas semanales durante 6 meses. Y utilizamos el esquema que se encuentra en el manual del capacitador. Es como yo lo he aprendido con la doctora Jones, empezando desde el saludo, la lectura del cuento y de la fábula, que es tan enriquecedor, no solamente para los niños, sino también para los participantes, y era que ellos tenían que reflexionar sobre ese cuento o sobre esa fábula, y directamente lo llevaban a la vida de estos niños. Ya que la doctora Jones me dio un poquito de tiempo, me gustaría compartir un cuentito que le habíamos contado, que es sobre el jarrón del comerciante. Un comerciante tenía un jarrón tan valioso que se le cae y se rompe en cientos de pedazos. Entonces la persona levanta los pedazos y lo va uniendo con un pegamento de oro. Entonces ese jarrón roto se convierte en un jarrón mucho más valioso, y eso nosotros lo trasladamos a la vida que tenemos con los niños. Nuestros niños están rotos en pedazos, pero nosotros ¿qué hacemos? Lo levantamos y lo pegamos con hilos de oro para que cada vez sean mejores. Entonces esto es lo que los participantes empiezan a reflexionar, y es como que sí, eso es lo que tenemos que hacer por nuestros niños. Por eso el cuento y la fábula nunca faltó, profe, tanto en las sesiones sincrónicas como en las virtuales, como en las sesiones presenciales. Bueno, las sesiones presenciales, que lo hicimos en 3 fases, cada fase terminaba con una clase presencial que duraba 16 horas. Estas imágenes son de las... ¿Parece que no funciona? ¿Sí? Bueno. La de arriba es una clase presencial, era muy interactiva, había mucha participación de todas las personas que estaban ahí, no solamente los participantes, sino todo el equipo del directorio que nos acompañó. La otra foto son de las clases virtuales, y la otra es del foro. En las clases virtuales asincrónicas utilizamos un método que lo adaptamos a la virtualidad. Entonces hacíamos trabajos grupales o trabajos individuales, que eran tareas. Los foros fue muy enriquecedor, porque con ellos habían debate, habían intercambio de experiencia que tenía cada participante en sus distintos lugares de trabajo, de los distintos, de las distintas comunidades, y el factor común era el consumo de sustancias. pero el resto era tan diferente, en algunos había tanta necesidad, tanta deficiencia, tanto dolor. Entonces sirvió bastante el foro como actividad asincrónica. Era un momento de mucho aprendizaje y también utilizamos vídeos. Por comentarle, tuvimos un video donde le enseñamos cómo las drogas afectaban el cerebro del niño. Pero la consigna era cómo contarle al niño eso en forma creativa. Entonces hubo muchas tareas muy interesantes. Algunos lo contaban a los niños en forma de cuentos, otros en forma de fábula. Hubo una música que lo adaptaron para contarle cómo las drogas le afectaban el cerebro. Una forma de comunicación con los niños bastante interesante. Realizamos los 6 cursos durante 6 meses y lo dividimos en 3 fases. La primera fase, que contenía el curso 1, intervenciones con los niños con trastornos por uso de sustancia, el curso 2 con las consideraciones generales, y terminaban esta fase con una clase presencial. La fase 2, que lo hicimos, que incluye el curso 3, la entrevista motivacional, el curso 4, teoría del apego, trauma y distrés, y en la tercera fase con el curso 5 y 6. El 5, que es la parte de farmacología, y el 6, las intervenciones con bagaje para la vida. Hicimos un trabajo colaborativo. Le invitamos a capacitadoras internacionales que dieron el sí y un apoyo incondicional. Por eso que la familia Child, que formó la profesora Jones, desde el 2016 seguimos juntas, seguimos ayudándonos, y entonces estas capacitadoras fueron a Paraguay sin recibir remuneración, pero con el corazón lleno de alegría porque saben que van a ser beneficiados muchos niños. La licenciada Valeria Frato de la Argentina, que dio la clase presencial de la fase 1, la licenciada Azucena Ábalos de Perú, que dio la clase presencial de la fase 2, y la licenciada Priscila Valladares de Chile, que fue la que culminó el curso con la última clase presencial. Las entrenadoras nacionales con la licenciada Naine González hicimos todo lo que se refiere a las sesiones virtuales, tanto sincrónicas como asincrónicas, y las evaluaciones correspondientes. Este es un cronograma más bien de las clases, pero el proyecto Child empieza en abril del 2023. En prácticamente 13 meses se hizo realidad y se culminó las clases. En abril creció esa necesidad de llegar esta capacitación Child a mucha gente por todo lo que ya habíamos dicho. Entonces se presenta la propuesta al ISUD capítulo Paraguay, donde el directorio, por supuesto, acepta esta propuesta. Entonces empezamos el proyecto, que fue bastante largo, porque era comunicarnos con la profesora Jones, que nos apoyó desde el comienzo, con la CICAR OEA, con ISUD Global y con el Plan Colombo, para tener las autorizaciones correspondientes y para tener también los materiales que necesitábamos para desarrollar este gran proyecto. Luego empezamos a trabajar sobre el perfil de los participantes. ¿Quiénes podían ser las personas que iban a ser capacitadas? ¿Están trabajando con niños? ¿No están trabajando con niños? Entonces, como pensamos llegar a lugares muy lejanos de nuestro país, pensamos en las personas que trabajan en los municipios, que son personas que están en contacto con los niños a través de un departamento de las municipalidades. Se hizo las invitaciones correspondientes a los 260 municipios. Se le invitó también a profesionales del Ministerio de la Niñez y la Adolescencia y de la Secretaría Nacional Antidroga. Eso fue en julio. En agosto íbamos recibiendo las notas de los postulantes, y en septiembre ya le enviábamos una nota de aceptación a los postulantes con una carta compromiso que tenía que firmarnos comprometiéndose en completar el curso, completar el curso, el pretest, el posttest y como también las actividades tanto presenciales como virtuales. Y el 15 de noviembre se cumple mi gran sueño, que es empezar la capacitación Child, que los hicimos primero con cursos virtuales y luego ya las presenciales. En total son 248 horas, de las cuales 48 horas son presenciales y 200 horas son sesiones virtuales, sincrónica y asincrónica. Desde abril hasta la actualidad son 13 meses de trabajo, pero las clases fueron de 6 meses. ¿Quiénes fueron los participantes? Los participantes fueron funcionarios técnicos de las municipalidades de diferentes partes del país, funcionarios técnicos del Ministerio de la Niñez y la Adolescencia y funcionarios técnicos de la Secretaría Nacional Antidroga. Este mapa es para mostrarle un poquitito, bueno, creo que no puedo señalar, cómo las personitas son las personas que fueron capacitadas y prácticamente abarcó casi todo el territorio paraguayo. Esta persona que está allá arriba, que está a 800 kilómetros de la capital, los niños de esa zona no tenían esa posibilidad de recibir una atención temprana y oportuna, que ahora lo va a recibir. Estos niños de estas zonas muy lejanas recién llegaban a la capital ya con patologías duales, ya con trastornos que afectaban mucho su parte psíquica como física. Entonces van a ser beneficiados miles de niños con esta capacitación. La financiación, que es muy importante, que hace posible que sea realidad este proyecto, la CICAT OEA fue la que se encargó de financiar la ida de las profesionales extranjeras, cubriendo pasaje, estadía y viático, y empresas privadas con compromisos sociales. En verdad que fueron 3 empresas privadas que nos ayudaron, y eso facilitó que las clases se hagan presenciales en un hotel con todo pago, los gastos, y que no recibió ningún costo para los participantes. Fue totalmente gratuito para todos los participantes. El resultado. Terminaron el proyecto, la capacitación, 22 personas, 22 profesionales que han adquirido herramientas y conocimientos con base científica que lo van a poder utilizar para las intervenciones con niños en sus localidades. Esa torta nos muestra que el pretest, esto se hizo como un promedio de la suma de los porcentajes de los pretest de todos los participantes y de los 6 cursos. El pretest arrojó 39.20%, que nos da la pauta que hubo muy poco conocimiento del contenido del currículum. Y el posttest, si ustedes se fijan, 78.30%, mucha diferencia con el pretest, que nos indica que hubo mucho aprendizaje con esta capacitación. Bueno, también hubo evaluaciones de los participantes sobre la capacitación, valoraron el contenido, como también la relevancia de los materiales. Acá lo que nos solicitaron era material en físico, que lastimosamente no lo pudimos dar porque ya pasaba nuestro presupuesto, pero sí compartimos con ellos en forma virtual. También evaluaron las competencias de los capacitadores y comentarios sobre la experiencia y el valor general sobre el curso en sí. Estas tortas hablan también, el primero el nivel del curso con relación a su expectativa. El 94.40%, la expectativa fue excelente, y 5.50% que fue muy bueno. Y la segunda torta que nos habla que el curso facilitó los temas del módulo de aplicación para implementar la instrucción en el tratamiento con niños con trastorno por uso de sustancias. Todos, el 100%, dijeron que sí, que este curso facilitó bastante las intervenciones que pueden realizar con los niños. Bueno, la capacitación CHILD para nosotros no termina acá. Nosotros tenemos este proyecto de seguir con todas estas personas que cumplieron esta capacitación, seguir la evaluación y el monitoreo de la implementación del curso CHILD. Y vamos a utilizar la herramienta Child Carmen, que esta medida es un instrumento que consiste en una entrevista semiestructurada que está diseñada para ser utilizada por personas capacitadas. Y es lo que vamos a hacer también en forma virtual, una capacitación sobre el uso de esta herramienta para que después lo podamos utilizar, y lo haremos antes la implementación a los 3 meses y luego a los 6 meses. Y con esto lo que vamos a estar midiendo es la diferencia que existe antes y después de la intervención. Y bueno, antes de despedirme, le quiero leer esta reflexión de Robert John Meehan, que es un catedrático norteamericano. Esto lo saqué del de la última página del curso 6 de Child, porque esto me inspira y me gusta muchísimo. Y bueno, y dice: si tus acciones inspiran a los niños para soñar más, para aprender más, para hacernos más y para hacer algo más, entonces verdaderamente merece ser llamado maestro. Y bueno, me despido de todos ustedes agradeciéndoles su atención. Awiyé, que significa gracias en mi dulce idioma guaraní, y thank you, que aprendí para despedirme de ustedes. Gracias, muchas gracias.
Thank you, Maria Carmen. And now we have Manish, who will be our final speaker today.
Thank you for having me here. It's indeed a privilege to be amongst all of you. So let me start my presentation by acknowledging the contribution of 3 incredible individuals sitting in this room. First and foremost, Dr. Rajesh. He has been working relentlessly for the last 40 years to understand the issues related to substance use, generating evidence, and translating that into the policy at not only at the state level but also at the central level. And he has been one of the instrumental person in shaping the policy of Government of India, what we have as of today, to address the issues related to substance use prevention and treatment. And I've been privileged to work with him for the last 15 years. We also have with us Mr. Sanjay Beniwal. He is a top cop, and I had privilege to work with him as well. And through him, we came to know that how prevention can be thought through to address the crime amongst children. And actually, the project what he had implemented in Delhi and Chandigarh proven to be a model for the entire country, and I'm happy to inform you that the same model is being replicated in 272 districts across the country, and that has been borrowed by Government of India, and it is being implemented in 272 vulnerable districts across the country. We also have with us Dr. Jones. She helped us think through the problem among children who are in the age group of 7 to 12. we were lucky enough to actually contextualize the suitcase for life in the Indian context, and that actually helped us reach to the unreached population which we could not cover earlier. So thank you for that. Having said so, let me start my presentation. I'll be speaking a bit about SPYM. So this is a 4 decades old organization. We were established in 1986, and we started working on substance use prevention and treatment in late 80s. Right now, we are working in 12 states across the country, and our footprint is primarily in northern part of the country. We also work in eastern part of the country and southern part of the country. So these 12 states we work directly, but in other states we work obviously with the partner organizations we have. In terms of partners, we work primarily with the government organizations at the central and state level. So we work primarily with Ministry of Social Justice and Empowerment, which is the nodal agency for substance use prevention and treatment in the country. We also work very closely with Ministry of Health and Welfare, Ministry of Women and Child Development. So these are the 3 critical ministries from the substance use prevention and treatment angle whom we work with. We also work with state counterparts of various Social Welfare Department and Department of Health in the states where we are having our presence. We also work with CSR foundations and bilateral and multilateral partners. In terms of program, I have put it in 4 different buckets. So primarily in healthcare, we work on substance use prevention and treatment. We also work on HIV, hepatitis C, and TB elimination, that is tuberculosis elimination in the country. We have privilege of working as a capacity building institution. So we work with organizations who work in the domain of substance use prevention and treatment in HIV, and we happen to be a training institution for these agencies across the country. We also work with more than 5 lakh homeless population in Delhi, because Delhi has a huge population of homeless, and we provide them basic services which includes clothing, shelter, food, and basic medical needs. And obviously we are also working in evidence generation, so we are working with Ministry of Health and Family Welfare as part of National Family Health Survey. We have also conducted survey to come up with the findings of National Drug Use Survey, which we have as evidence to support the program implementation as of now across the country. So this is how we are positioned in terms of our work. Now coming to substance use, Dr. Jones has talked about it, but I'll give you 3 specific data sources on the basis of which we will come to know that how serious the problem is as of now. So I'm putting the first data source, that is the magnitude of substance use in India. So this study was conducted way back in 2018, and this is the most recent data we have in terms of prevalence of substance use among different population groups. So if we look at the data of 10 to 17 years of age group, we have problem of inhalants, we have problem of opioids. And if you look at the prevalence of opioid among adults, it is 2.1%, but in case of children, it is 1.8%. So that is quite concerning for us. If we translate this percentage into numbers, we will come to know that the number of opioid users among children, that is 10 to 17 years of age group, comes to around 4 million. In case of inhalant users, it is 2.6 million, and in case of cannabis users, it is 2 million. So we have a substantial population base to cover as far as our treatment program is concerned. There was another thematic studies as part of the National Drug Use Survey, which was conducted among school children, and that data is also saying the very same language or speaking the same language. So among the school children, 15% reported to have ever used drug. And among them, the current users are close to 50%. So 7% of the respondents were actually the current users. And again, in this case also, alcohol, opioid, and cannabis are the predominant choice of drug which were reported as part of the study. Now, if you look at the rate through which this consumption increases, so after 13 years, so average age of substance use initiation is 13 years, but it gets doubled after 13 years of age. And the concerning part is just 1% of them actually have sought any kind of help as far as treatment or counseling support is concerned. And we have substantial population of street children, and as Dr. Jones rightly pointed out, among them the substance use is quite significant. There is another study which was conducted by National Commission for Protection of Child Rights in 2014, and it also says the very same thing. But one thing which is more concerning is sexual abuse among children who are into substance use, and that increases their vulnerability not only to HIV, STIs, but also to a certain extent towards hepatitis. And in the most recent campaign conducted across the country, what we have started witnessing is among juveniles we have Hep C prevalence, we have HIV prevalence, and that is actually multiplying the issues related to substance use to many-fold. Now, one of the reasons why this particular population needs to be looked at is because significant number of children who are into substance use have reported that one of the family members are actually using drug, and that is something what increases their risk and vulnerability towards substance use. Broken family and violence within the family are other contributory factors which is actually leading to substance use among children. As per National Crime Bureau record, we have seen a rise of around 88% among drug-related crime among juveniles. So that's a substantial increase in terms of crime among juveniles, as reported by the government data. So this is where we are in terms of the situation at hand. Now, coming to how we are responding, how SPOM is responding to this particular situation. So we have two different arms to address this particular problem. One arm is prevention, and another arm is obviously treatment. So in drug prevention program, we have started the largest prevention program through schools across the country. So SPOM has developed for Ministry of Social Justice and Environment a curriculum called Navchetna. Navchetna is a new consciousness, and this is a life skill based education program, and we have tried to integrate it into the school system so that it becomes a regular feature of the schooling as far as the drug treatment or drug education is concerned. So this program was launched by the Government of India. So you can see the Home Minister who is launching this particular program way back in 2022. So these are two different curricula we have. One is for 6th, 7th and 8th grade of student, and another curricula is for 9th, 10th and 11th grade students. And these are primarily life skill education based curricula, and drug is just one of the chapter which comes at the end. So idea is to help people understand through life skill education what the drug is, what are the negative consequences of drug use, and how they can stay away from drug use during the course of their life. Target of this particular program is to reach to 1 million teachers across the country, that is 28 states and 8 union territories. So this is a target to train number of teachers across the country. And for this, why it is important to understand this, because unless you make it part of the routine system or government system, this cannot be taken to a scale and this cannot be made sustainable. So we have created a model and we have tried to integrate it as part of the routine system. So we had a MOU, Memorandum of Understanding, between Ministry of Social Justice and Empowerment and Ministry of Education, because Ministry of Education actually takes care of the entire schooling system or university system in the country. So they had a MOU, and all the counterparts at the state level, that is State Council of Education, Research and Training, they were asked to nominate teachers from their provinces to get themselves trained, and then further roll it out across the state in various schools. So target was to train 1 million teachers across the country, and in 2 years' time we are targeting to reach to 50 million students, and a total of $5 million have been allocated by the Ministry of Social Justice and Environment for this particular project. So this is the scale what we are looking at in terms of drug prevention education in the school setting. This is the status as of today. So we have rolled this out in 18 states of the country, and 54,000 odd teachers have been trained, and some of the states have started actually implementing the program at the school level. So this is being now made part of the routine curriculum of various schools to take this process forward. Second bit is community-based intervention, and this is for primarily for those who are not part of the school system. And again, idea is to help them understand issues related to substance use through life skill approach. And this is also creates an opportunity for us to identify children who need support so that they can be provided counseling support or linkage with the treatment services, whatever is available in the community or in the vicinity. So this is how we have started implementing community-based intervention. Now, these are the 8 or 9 modules what Dr. Jones was referring to in her presentation. So again, this is life skill based, and at the end of the course, this is basically a 3-month course. At the end of the course, we start talking about drug related issues, and by then the children are very much comfortable. They open up and they start sharing the issues they have at hand, be it at the personal level or at the family level, and that is how we start them feel and understand that why drug is an important issue for them, and why they need to come for support as and when they require it. Now, in terms of outcome, I'm just referring to one particular geography. So in Chandigarh, we reached to around 4,000 vulnerable children. And what we witnessed as part of the impact assessment study, that there is a substantial increase in substance use related absenteeism to the school, because obviously they were out of the school, and our focus was also to reinstate them with the schooling system. So absenteeism has come down. Significant, almost 2/3 of them actually found themselves confident in terms of refusal skills. They could say no to their friends when it comes to substance use. Juvenile related crime actually got reduced, and this is as per the government data. So 50% reduction in juvenile apprehended for petty crimes in Chandigarh was reported. And as I stated earlier, this model has been taken up by the Ministry of Social Justice and Empowerment, and it is being replicated in 272 vulnerable districts across the country. Another set of approach we have for the community-based intervention is, we call it outreach and drop-in center. So this is a targeted intervention kind of concept, wherein we try to create a safe space which is non-discriminating or non-stigmatizing for the drug-using population who are in the early stage of drug use. So they come and be part of the system as long as they want to, and this provides us an opportunity to interact with them and provide them necessary support what they intend to receive from us. So this actually provides us a platform to give them counseling sessions, help them understand that why they need to come out of drug using issues, and if they need some treatment support, they can be linked with the treatment services available in and around that area. So this is how we approach early initiator of substance use through our intervention. Now, coming to drug treatment and rehabilitation, so this is the treatment arm of our program. It has been a bit of journey. So we started working with trafficked street children initially with intervention coming from the judicial system and police, and they were instrumental in terms of setting up this particular system. And sometimes it is difficult to actually comprehend that police is helping you set up this kind of system, but this is the reality. So we, with the help of police, we had set up a system called Health Center at the railway station, and by doing that, we started mobilizing street children, those who needed our support. We also trained paralegal volunteers and police personnel so that they can be a mobilizer for us in terms of identifying these children and helping them come to the center where services are available. So this is how we started, and just to make it a sustainable model or take it to a scale, we had advocacy with the health department, and in 7 hospitals in Delhi, we had 10 beds earmarked for detoxification purposes. And why it is important? Because substance using population come with so many comorbid conditions. Like I talked about hepatitis C, I talked about HIV, I talked about abscess. So unless you have a hospital system, it will be difficult for you to address all these comorbid conditions in one go. So the hospitals were identified and beds were earmarked so that detox can happen in the hospital setup. Once they were detoxified, they were sent to our center for rehabilitation purposes. And then in 2011, we had our first center for boys, and this was primarily meant for children who were in conflict with law. And in 2016, we set up our first center for girls or women. So this is how we have progressed over a period of time in terms of setting up our center for boys and girls. So these are the key stakeholders. We work with police, we work with Women and Child Development Department, Juvenile Justice Committee or Board. Of course, we are acknowledging the contribution of INL and Colombo plant because they helped us set up this particular system. We also work very closely with Child Welfare Committee. So these are the key stakeholders we have to implement the program, what we are implementing for substance use prevention and treatment. So we were fortunate to have our Chief Justice of Supreme Court of India inaugurate this particular center, which was inaugurated on 20th April 2011. And through this center, we specifically targeted children who were in the age group of 7 to 18. And idea was to help them go through this 3 months comprehensive treatment rehabilitation program in our setting. These are the services what we offer. So whenever a child comes to our center, the child is oriented about this center setup. Then they are assessed, so basic socio-demographic profile or basic profile of that particular children, understanding the substance use history, and then the person is referred to the hospital for detoxification purposes. So the entire detoxification happens in the hospital setup, and once the person is detoxified, the person is again referred back to our system, that is rehab center, and there we provide the psychosocial intervention, various sets of counseling issues. As part of the process, we do acknowledge the contribution of the family or involvement of the family in the treatment process. So one of the key element what we look at is how do we involve family or engage family as part of the process so that the recovery is sustained once the person is out of the treatment center. So these are the therapies we generally practice in our program. We also focus on vocational training and non-formal education because good number of children who come to our center are not literate. So how do we make them literate, and how do we make them be part of the formal education system is something what we work around. So our first girl center was started in 2016. It's a 20-bed facility, and we have girls or women in the age group of 7 to 35 as part of the center. Again, this is a 3 months comprehensive treatment center, and this center was inaugurated by the Deputy Chief Minister of Delhi NCR. So this is what we offer to the girls coming to this center. Again, more than 300 girls have been treated in our center since inception. Now, the program is not without any challenge, so we do have some challenges. The first and foremost is still we have some reluctance on part of the policymakers to look at substance use among women and children. So they are yet to conceive that this is a problem, or they are yet to accept that this is a problem and this needs to be addressed. Because of stigma, families are still in denial, and we do not receive the support what we intend to receive from them. And this is critical because once the person is out of the center, certainly family has a very, very important role to play in terms of sustaining the recovery of that individual. So family's role is very important, but there are issues what we are facing from the family side. Schools are yet to accept this, and particularly I'm talking about schools who are meant for elite section of the society, because they always attach this with the stigma related to this or attached to this, because they feel that if they report substance use related cases, certainly the brand name of or brand of that school is going to get hit. So even if the problem is there, they are yet to accept it that this is happening in their backyard. And obviously, we all are struggling with the funding support. So inadequate funding support is something one of the greater challenge what we have, because unless you have funding support, you cannot take these models to a scale, and this cannot be replicated all across country. So these are the challenges what we have as of today. So to conclude, we all understand that early intervention is very, very critical and it is crucial, particularly addressing substance use disorder among children and youth. Community-based outreach is very, very important, because that way you are reaching out to the population which is not part of the formal education system, and this also helps you in a sense prevent relapse, because unless you have the outreach system or community-based system in place, you will not be able to actually do the follow-up as required under the program, and this will not help you actually prevent the relapse. So from that perspective, community-based outreach is very, very important component of the program. Involving families in treatment is very, very critical, and again, as I said earlier, they are critical because they are one of the important pillar to sustain the recovery of individuals who are getting treated in our center. So greater involvement of families in treatment per se is very, very important, and certainly we need to scale up the intervention we have for children and women, and obviously their needs are entirely different from the needs of male-centric drug treatment program. So the entire program for children and women needs to be tailor-made, and this needs to be scaled up across the country as per the evidence we have in terms of problem at hand. Thank you.
Thank you, Manish, for a beautiful, impactful, and powerful presentation. I want to open it up. We have several minutes for questions, so we would love to hear from you all, having listened to the 3 presentations. What questions do you all have? Yeah, please.
Thank you. I'm from Bulgaria. I would like to ask if there is a follow-up after the children complete the program. How do you follow up and proceed with the? Do you know what happens with these children after the program?
So generally in our program, we do follow them up for almost 3 months post their discharge from the center. And that is why I said community outreach is very, very important, because unless the workers go and meet them in person. Now, there could be 2 different situations. One is the person is from the geography where you are operating the center from. So in that case, we go for physical follow-up. So the outreach team goes to the doorstep of that individual and actually does the follow-up, so that we can be sure that the person has not relapsed, or whatever support the person requires, he can be referred back to the center. So that is one way of looking at it. If the person is not from the same geography, if they are from different province, then we do the follow-up over phone. So we have both telephonic follow-up and physical follow-up to make sure that the person does not relapse over a period of time. Since the scale is so huge, it is not possible for us to do each individual follow-up post 3 months period. But they are encouraged to come to the center as and when they feel like, for counseling support or for treatment support, so that they are out of the drug use over a longer period of time.
Very important question for, especially in the case of children. No child comes to us directly. The child is referred to us by 2 quasi-judicial bodies. One is called Juvenile Justice Board, when the child is in conflict with law. So this is a principal magistrate heads that, and there are 2 board members, one psychologist, one social worker. Another is a child welfare committee, where the child has not committed crime. It could be a street child, it could be a vagabond. So when the child comes to us, when the child is about to be discharged, so in discharge order, the Juvenile Justice Committee will write it that for next 6 months, you have to bring your child to the treatment for counseling and other support. And next 6 months, what Manish has said, we reach out to them. And again, as part of the study what Dr. Jones has done, we do the urine test. So whether the child is what is our family is saying is correct or not. So in the urine test also, I think it was quite visible that they were not using drug. So and the third thing what we have done, again it's a unique thing. What we did from that in a particular area, if there are 5, 7, 8 families are there, so we help those 5, 7, 8 families to come together to understand the problem. And there was a photo where the family members are sitting together. So in that what happens, each family member is in contact with other 7, 8. So if his child is behaving something which they feel that is weird, it should not be, then they consult the people, those who are from the children, those who are in recovery for longer period. So these are the 3 strategies we do. Thank you. Homeless children, there is those who are children below 18. There is a government. That's a government responsibility. So government has opened it's called children home. So the child from our center is again produced in front of a child welfare committee, and child welfare committee will order to the government that take this child in your children home and provide whatever the services like education, food, health, and even after 18, they are supposed to be provided support for next 2 to 3 years vocational training and linkage with this other services.
Are there other questions for our panelists? Dee, go ahead.
Sorry, I have 2 questions. One question related with teenager, the teaching for the children. I wonder that because we are just in Vietnam just change the law of maybe the children under 12 years maybe put in rehabilitation center. I would like to your advice about it could be better for the children to remove from their community or provide a treatment for the children in their community. This is the first question, and the second question is related with treatment for the women with substance abuse, but sex workers who are use substance because they work rather than like I don't know. What is the strategy for the treating for the women who use substance and high risk HIV population? Thank you.
So let me just, Avi, let me make sure that I understood your 2 questions. So the first question to our 2 panelists is it better to treat the children in the community or to get them out of the community and into a residential setting? Did I get that right, Vi? Let's answer that one and then we'll hold the women one. So and I'd like to hear from both Manish as well as Dr. Maria Carmen.
Bueno, entendí que la pregunta es cómo tratan a los chicos, a los adolescentes, si los hacen de forma individual o también incluyéndole a la familia, a la sociedad. Creo que fue esa la pregunta. Bueno, en Paraguay nosotros el tratamiento que le damos a los chicos es siempre acompañados de la familia, porque estamos hablando de un menor de edad. En caso de no tener un miembro de la familia, lo estamos haciendo a través de personas referentes de los mismos, ya sea de alguna institución que se hace cargo de ellos, sobre todo los niños en situación de calle, que generalmente son intervenidos por funcionarios del Ministerio de la Niñez y de la Adolescencia. Ellos hacen trabajo en calle. No van en el lugar en donde están los chicos, hacen en primer lugar un tipo acercamiento a los mismos, ¿verdad? Se sientan con ellos en la calle, ellos bajan al lugar en que están los chicos, le llevan un poco de golosinas, entonces hace ese vínculo con el chico y luego lo convence de ir a tratamiento. Esto no es que lo hacen en un día, Esto es todo un proceso. Algunos sí lo logran con poco tiempo, otros inclusive hasta semanas le llevan a convencerle a este chico de ir a terapia. Entonces, el seguimiento, ¿cómo lo hacen? A través de ese funcionario que hizo la intervención. Es su referente positivo. Vendría a ser como parte de su familia. Y los chicos que tienen vínculos familiares, generalmente las intervenciones se hacen con la familia y dentro de la comunidad. Porque eso es muy importante, porque si vos le tratás al chico, permanece en abstinencia, pero después va nuevamente a una comunidad contaminada por las drogas, por supuesto que va a haber recaída. Entonces es como un círculo, individuo, familia, sociedad o comunidad.
Okay, so in terms of prevention and intervention, we do have intervention at the community itself. So what we do generally, we map the communities where we have significant chunk of children who are into substance use or vulnerable to substance use, and we try to set up intervention in that community itself so that they can avail services. And we keep on rotating the site so that we can cover more and more more and more vulnerable pockets over a period of time. But when it comes to treatment, it all depends whether the treatment services are available in that particular community, yes or no. If it is available, they can come and avail those services, but if it is not there, they will have to certainly go to a place where the treatment services are available. So from prevention angle, it is at the community itself, so they can avail services within the while remaining in the community. But in case of treatment, obviously it depends on where the treatment services are located. Yeah.
Sorry. No, it's a very good question. When we designed our project, in fact, Mr. Beniwal is the person who helped us to do the first trial in 2017. We never budgeted place for the intervention. We said, we will bring our resource, you have to provide your space. Space means it could be someone's house, it could be someone's the rooftop. So it was a community-owned program for the prevention. Now in treatment, since all of us are here professional, the dependency of any substances for the children is a very short period. Could be 6 months, could be 1 year, could be 1.5 or 2 years. So the detox is much easier, but the problem is more behavioral, and that is not possible in a population who has not been habilitated. Please remember, rehabilitation will come only when the person is habilitated. If the child has not been habilitated, like if you start looking at the slide, second or third slide, where it says family violence, dysfunctional family, the neighborhood, both parents are working somewhere. So there we need some sort of it could be a residential program or it could be a daycare program where the life skill based. We have, if you are interested, we can provide you this, if you write to us online, these two modules. So in these two modules, we have whatever we have done here, that is also part of the community setting. So detox could be done in a hospital setting, 4 days, 5 days, 3 days, and if they are HIV positive, they have TB, they have Hep C, those could be also addressed. And generally, around 20% kids we found that they have these comorbidities. But life skill based, either it could be if the community provides space, it could be there or it could be in a residential setting. Thank you.
And V, you had a question about women's treatment. And can you just restate what the particular piece was about women's treatment?
I wonder that how to provide the service for women use substance, but she also the sex worker.
Okay. Yeah. Yeah. Okay. Perfect.
Okay. So in case of women who is into sex work and who is also a substance using person, generally what we see in our setting, these individuals are dependent on opioids. So we have an outpatient opioid assisted treatment program or opioid substitution treatment program. So they can come and be part of the program, and this is a OPD based program. So You need to come, get yourself assessed. You can be initiated on treatment, and every day you have to come and just take the medication as per your own convenience. So the program opens at 8 o'clock in the morning and it goes up to 3 o'clock in the evening, right? So it is all up to you what time you want to come and avail the services. So this not only includes the treatment part, this also includes the psychosocial intervention part, and that is how we address the problem related to opioid use among sex work population. If they are dependent on alcohol, they can also be treated on a OPD basis. So depending on what kind of treatment the person is looking at, instead of having them as part of the residential treatment facility, we can get them treated as part of the OPD facility as well.
All right, so I have one final thing, and I'm going to do this for Dr. Kumar. I'm going to invite everyone to stand up, and we're going to do a very brief exercise that we do with the children, because it's important to get in touch with our childlike sides and feelings. And so if everyone would stand up and start moving your feet. And I want you to feel your feet on the ground, because we are grounded and the ground holds us. I'm going to invite you to stretch your arms up, and that might feel a little uncomfortable, but that's how we grow. And then I'm going to ask you to spread your arms out like wings. And the wings are the wings of hope for a brighter future. And now I'm going to invite you to hug the most important person in your world right now, you. There you go. A tip, a tool that you can use with any patient you work with. Thank you for being here today. I appreciate all of you. Thank you.